Welcome to tonight's Us to Black Men's Prostate Cancer Initiative webinar on what Black men need to know about prostate cancer. Before we get started, a couple quick disclosures for everybody. The information and opinions expressed in this presentation are not recommendations by us for any medical treatment, product, service, or course of action. Please consult your doctor about your specific situation before embarking on any health program or treatment. And now that that's through, I want to let you guys know about the chat feature. So any participant in the audience can send questions through the Q&A feature down at the bottom of their screen. Please note, we will be monitoring the Q&A during the session, but we also received a number of questions prior to registration. So we'll try to get to as many questions as possible. And also, please use the chat box to let us know where you're joining us from or to send a supportive comment for the panelists. So again, welcome everybody. My name is Jamie Kearns. I'm a urologic oncologist at Atrium Health Living Cancer Institute in Charlotte, North Carolina. And I'm fortunate to get to focus my clinical practice on taking care of men with prostate cancer. But enough about me. You guys are here to hear from our panelists tonight, and so I'd love to introduce you to Dr. Yao Naimi, a very good friend of mine. He attended medical school at the Feinberg School of Medicine at Northwestern University and business school at Kellogg School of Management at Northwestern University, graduating in 2012. Prior to medical school, he completed a master's in health services and administration at the School of Public Health at the George Washington University. Dr. Naimi completed his general surgery internship and urology residency training at the Glickman Urological Kidney Institute at the Cleveland Clinic. He came to the Northwest to complete the premier Society of Urologic Oncology accredited fellowship at the University of Washington and joined the faculty upon completion of his training. Dr. Naimi has a research interest in health disparities in urologic cancers with a focus on both the molecular epigenomic and health services aspects of health inequities in prostate cancer and other urologic malignancies. Also joining us is Mr. Robert Ginyard, who is a prostate cancer survivor and chairman of the board at Zero, the End of Prostate Cancer in Baltimore, Maryland. Robert Ginyard is an entrepreneur, speaker, and prostate cancer survivor. As a result of his prostate cancer journey, Robert created DBDB, Dream It, Believe It, Do It, Be It, an awareness campaign and lifestyle brand to encourage people to live out their dreams. Additionally, Robert serves as creator, producer, and host of Intentionally Overheard with Robert Ginyard, a podcast that highlights the stories of people who dared to dream and committed to making their dreams come true. Robert has appeared before Congress, the Senate Appropriations Committee, to share his prostate cancer story and advocate for increased funding for prostate cancer research. He currently serves as the chairman of the board of directors of Zero, the End of Prostate Cancer. Robert has been named one of the Cancer Health Magazine's 2020 Changemakers, making a difference for others living with cancer. Robert lives in Baltimore with his wife, Karen, and their 2 daughters. And just for the audience to know, we've decided as a panel to refer to each other with our first names in the spirit of collegiality. And so without further ado, I would love to turn it over to my good friend Yao Naimi, who is going to give us a short presentation to get us started.
Good evening, everyone. I'm really excited to be here today with Jamie, who's a good friend from training and someone that I continue to collaborate with, and Robert, who I've gotten to know in the last couple of weeks, who's really an inspiration for why what we do matters. But I thought I'd start with a brief presentation that I'd given to some of our patient advocates here in Seattle about prostate cancer disparities. So I'm going to get some slides open here. So one of the ways that I really enjoy talking about prostate cancer disparities is looking at maps. I think maps tell us so much about who we are and the way we live, our values and our experiences. And this first map is showing the United States and highlighting by county level the highest producing counties of cotton in the 19th century. And it's no surprise that we have highlighted in the southeastern United States the strip known as the Cotton Belt um, as the highest producers of cotton. And there is a significance to this because we know that this production of cotton also coincided with the slave trade and has really significant social and economic implications in the United States. And this particular region of the country caught my attention during our election. As an economist was talking about the significance of the Cotton Belt as being the small strip of blue that we typically see in an otherwise fairly red region of the country. And so as I stared at the map on election day, I was thinking to myself, like, why does this look so familiar to me? Like, what is the significance of this region? This is an important history. And I think the reason it jumped out to me is because I had been staring at this map of prostate cancer death by county in the United States from 2014 for a lot of my research. And there was that same cotton belt highlighting the region of the country where we see the highest prostate cancer deaths in the United States. And I think it's not a surprise that if I were to show you a map of the United States Black population, that again, its highest concentration is going to be here in the Cotton Belt. However, we have populations, significant Black populations in many urban centers throughout the country, and you can see them here on this map. Here we are in Seattle in the Northwest with a population that is present and significant. And so, you know, here's a graph that shows the reality of prostate cancer disparities in the United States. And I think there's several numbers that we'll talk about today, but really the one that stands out the most is deaths over time. And so here in the US, we've been collecting cancer statistics since 2000, since the late 70s. If you look from the late 70s to 2020, the rate of death for Black men is about twice as high compared to men of all other races. And that's been pretty steady, even with the introduction of PSA testing in the late 80s, which has subsequently led to about a 50% decrease in men dying from prostate cancer. So 1 in 7 Black men are going to be diagnosed with prostate cancer in their lifetime. That's compared to 1 in 9 for men of other races and ethnicities, or men in the general population. Black men are about 60 to 80% more likely to be diagnosed with prostate cancer. They're twice as likely to die. And I think every time I present those statistics to an audience, the first question I get is, well, is this biology? You know, what's unique about Black men that leads them to have a higher risk of prostate cancer and potentially more aggressive prostate cancer? You know, in fact, Black men are more likely to be diagnosed at a younger age with prostate cancer, and they're more likely to be diagnosed with advanced or late stage cancers compared to other men. Well, I think rather than honing in on biology, let's start with this concept of social determinants of health. So in the early 2000s, the World Health Organization really prioritized global health disparities as its mission, looking at developing countries and the burden of, you know, common diseases among them. And they really helped to popularize this concept of social determinants of health. And I think everybody on this webinar can look at these parameters, you know, how much money you have, how safe you feel in your environment, how supportive and how well resourced your environment is, your education level, your access to good, healthy food, the community and the social structures that are around you, and your healthcare systems, how all those things can really impact your risk of developing any disease, really, and your ability to survive and be treated. So in prostate cancer, I think this is what it really looks like when you start to think about your risk of disease and your risk of dying. in relationship to these social determinants of health. It's really hard to measure this in the test tube, and I think that's one of the limitations of our current biologic studies. But we can all understand how your physical and your emotional stress may drive disease, your metabolic stress. So do you have access to fresh fruits or vegetables, or just processed foods? What's the impact of a lifetime of only having access to processed foods in your communities? Environmental stress, you know, is there violence in the neighborhood that you are in? Is there a lot of poverty? How do you capture and quantify what that impact is on the human body? And we all know of diseases that we learn in medical school, in the medical community, I should say. We're very familiar with these diseases that manifest from severe physical, emotional, or environmental stress. And lastly, uh, populations of color, people of color, and our Black populations are much more likely to be exposed to environmental pollution, whether it be in the form of lack of clean water, or having highways built through your neighborhoods, or having the power plant be nearby. And so all of these things you can see how all of this plays with the different determinants of health that I described in the last slide. But overlying all of that really are these social determinants of equity. So these are the things like the laws and the policies that guide these principles. Are there institutional or structural racism that are dictating your access to food? What are the economic policies that allow for you to get an education? And so the social determinants of health are really bound by our social determinants of equity. So I won't spend a lot of time going through this conceptual model, but the way that we started to think about this research here at the University of Washington was, you have a man over his lifetime being exposed to some factors that might increase our risk for prostate cancer. For instance, we know prostate cancer runs in families. So, is there a strong family history of prostate cancer? Is there a strong family history of colon or breast or ovarian cancers, right? Because we know those things run in families as well, and they impact your risk of developing prostate cancer. We also thought about environmental exposures. And ultimately, these things can lead to the formation of a cancer. This is a term, what we term carcinogenesis. And as we thought about the track of moving through the development of cancer to a new diagnosis to treatments, there are all these opportunities where we can impact or affect your outcome, right? We can cure you by detecting your cancer really early, so screening, and then treating you with high quality care and timely care. And so each one of these components that you see on the graph, like access to screening and prostate biopsy, these are opportunities where disparities or inequities in prostate cancer care can be altered. And so we identified a series of areas to focus on, and we've been in a very methodologic way, we've been trying to do research to highlight opportunities to improve care. And so a couple of weeks ago, we published a paper in the journal of the National Cancer Institute that showed that if we increase screening, for instance, in Black men, and by increasing screening, we meant decreasing the starting screening age from 55 to 45, and screening men till the age of 70 every year. And using some modeling data, we found that we could decrease the number of Black men who died from prostate cancer by an additional 10% compared to standard screening practices here in the US. But one of the problems we face in general when we talk about disparities is that Black men are underrepresented in most of the studies that we use to set our guidelines. In fact, despite being having higher incidence or being more likely to be diagnosed with prostate cancer in a given year and being twice as likely to die, Black men are only representing about 3% of our studies that help set our guidelines. And because of that, we don't have opportunities to advocate based off the existing data for equitable screening and treatment solutions that may help create a more level playing field for this uniquely at-risk population. So what are the barriers to equity in prostate cancer care and research? I think oftentimes when we talk about uh, medical abuse and mistrust in research, we think about the picture on the right. So on the right is the Tuskegee trial, 600 men being exposed in the 30s to a natural history study of syphilis. They were under the impression they were getting treatment, but instead the researchers were watching to see how these men would live and eventually die with syphilis. And they recorded that almost for 40 years. But this recent story of medical abuse is just one of many, many, many examples, and something that's not unique just to the 20th century, but dates back to earlier history in the U.S. So the picture on the left shows Anarcha. Anarcha, Betsy, and Lucy were three slaves that were experimented on by J. Marion Sims, a surgeon here with his arms folded. He was long regarded as the father of gynecologic surgery. It is believed that J. Marion Sims performed over 30 vaginal surgeries on Anarcha without anesthesia using materials that really are traumatic, like silver suture, to repair a hole that existed between her bladder and her vagina that occurred after childbirth. This kind of trauma is not, it's not unique, again, to any one time period. It is transgenerational. It is something that our families talk about. It is something that is deeply rooted in the community. And so when we talk about medical mistrust, it's not something that happens in one doctor's visit. These experiences shape the community's cultural health beliefs. And it's important to remember that poor people and people of color in the U.S. have served as the quote medical material. So, hospitals that had high populations of Black men and women or poor Americans often advertised to their medical students that they would have individuals to essentially practice on. And if you want to read more about this, Harriet Washington's book, Medical Apartheid, it's a difficult read, but it goes into great detail, highlighting stories of people coming in with minor injuries and leaving the hospital with an amputation. So there is a lot to undo and unpack here. And those are all further compounded by social determinants of health and social determinants of equity, which very much exists in the community. And so how do we overcome these barriers? I think it takes a really concerted effort to do this together. So the PCORI, which is a Patient-Centered Outcomes Research Institute, really has been driving patient-centered research. And the four pillars of it are things that I think make a lot of sense to be a foundation to addressing health inequities. Those things are reciprocal relationships, cooperative learning, partnership, transparency, honesty, and trust. Using these four pillars for research allows us to have really robust discussions and develop research ideas that are created by the community for the community. And for me, I've been really lucky to have a variety of partners here in Seattle that are helping us do this kind of work locally. We created this coalition backpack this year. Here, Ben Young, on the left, Victor Tolbert, a young athletic trainer and a big health advocate in the community. Ben himself is a survivor and is a really integral member of our team. And this is Dante Moorhead, who is a public health researcher that is helping with our efforts. And we feel that by having this kind of a team and getting out to the community to learn about the needs of the community and how we can help is an integral first step. And we look forward to not only learning about what the needs are, but involving patients, caregivers, advocates in the prioritization, the development of research questions that address directly inequities in healthcare. So as always, when you do this kind of work, a lot of people to thank. For me, a lot of folks here in Seattle at the University of Washington, at the Fred Hutch, and our funders. And I thank you for giving me this opportunity to come share some information and knowledge, but also more importantly for me to listen and understand what you're going through and how we can start to make a difference in this space.
Yeah, thank you for that. That was a really fantastic introduction, and I think really lays the groundwork for what we're talking about here. I think social determinants of health are so critically important to understanding this topic. And I want to get Robert's opinions as well, but I think one of the first questions that really pops up in my mind, and it's probably the crux of all of this, so I don't expect you to have the answer in just a sentence or two, but do you think, if you had to really place your emphasis on one thing, that it's a social determinants of health thing, where access and all the rich history and really long history of discrimination and institutionalized racism go into this? Or do you think that there's a strong biologic basis to the disparities that we see? Or do you think it really is a combination of both?
It's such a fascinating question, because the truth of the matter is all the things are happening at once. And I think oftentimes when we talk about biology in disparities or health inequities, we're coming from this framework of trying to dismiss or excuse the pattern of care with biology. Okay, so it's this sort of this idea of a deficit model. So we say, well, Black men are twice as likely to die from prostate cancer. The inference that's then immediately made is they must have some kind of innate genetic or biologic predisposition that causes that. And then when you allow that to happen, then you can sort of excuse that outcome, right? And that's pretty common phenomenon in medicine. In fact, the concept of race is something that we as a medical society have propagated over the centuries as being important, and really have set the boundaries around that. The truth of the matter is, if you think of race, which is a social construct, purely as that, then the overwhelming majority of what we see is observed by the social impacts of how we view race. Within that is a lot of access to care issues and, how do you prioritize getting your PSA screening and getting food on the table sometimes, right? Or how do you prioritize your safety and getting a PSA test every year? Those are real world problems that aren't easy to solve with any biology. But at the same time, how do you measure the impact of a lifetime of pollution, right? That's going to have a biologic impact, even though that is rooted in a social foundation. That might be an explanation for having more aggressive cancer or being more likely to be diagnosed with cancer.
Awesome. Robert, I'd love to hear your thoughts and some initial questions that you may have coming out of this discussion.
Sure. Well, I definitely think in terms of the social determinants that they play such a huge role with men and prostate cancer and just in life in general. One of the things that, it's always interesting when we talk about, Black men's prostate cancer versus white men's prostate cancer. And, you could have two gentlemen with the same level of care. And, y'all mentioned it earlier that, you really can't, you can't diagnose this in a test tube. So if you got two men with similar backgrounds and, educational levels and, family life and all of that, but then there's this other thing in the Black man that his cancer is more aggressive. And one of the things that I really believe plays a major part in that is that stress of being Black in America. There is a stress level that some of my white colleagues can never understand. Just the stress of knowing that when you leave the house and in your car, it's a kind of a stress that's under the surface, but it's always there because you really, as much as you think you are in control of your life, in an instant that if an officer has a bad day, you could possibly be the subject of a really bad outcome. And so that's a constant stress. I also use this example, Jamie. I remember once I was giving a keynote speech at an event, and I entered the elevator, and there was a white woman on the elevator. And I got on the elevator, and I'm suit and tied up and ready to give this big speech. And the woman clutched her purse. And so right away, I'm thinking, man, it doesn't matter if I was in blue jeans or suit. That stress of how do I win? And ironically, we go down to the speech that I'm giving, and this woman is in the audience. So I'm giving this presentation, and I'm seeing this lady and wondering how does she really recognize me? And so those are some of the things that we go through on a day in and day out basis. And so that's that other X factor that I think causes us to have more aggressive outcomes in terms of our cancer. So I'm just really a big believer that particularly stress has a way of manifesting itself in some part of your body, in this particular case, prostate cancer. It has a way of manifesting itself. And with all of the external stress, the environmental stress that's going on around that, I think that definitely plays a huge role in how your cancer progresses.
Absolutely. I think that's an excellent set of points. Kind of getting into the meat of things then. So when should Black men get screened for prostate cancer? Should every Black man get screened for prostate cancer? And how should they go about doing that?
Yeah, I mean, it's a great question. If you look at the U.S. Preventative Service Task Force recommendation, they acknowledge that men with a family history and Black men are at higher risk of developing prostate cancer and likely more aggressive cancer, but essentially state that because there's a lack of level 1, which is for those in the audience, that's the type of evidence where if we give you a test or no test or a pill or a sugar pill, and we test which one works, that's that level of evidence that we use often to set our standards. And so for prostate cancer screening, the excuse for Black men has been that kind of level 1 evidence doesn't exist. As I mentioned, 3% or less. I mean, one of the studies that we routinely use to set our guidelines was a European trial that essentially had 0% representation of men of African ancestry. So if you base it on that, then you say there's nothing to be done. But there's very rich history to demonstrate that screening strategies starting as low as in the age of 40 can be beneficial. We recently published some data saying age 45. The key thing about screening is really the PSA test. I mean, that really drives the most value with regards to getting a test. But if you're going to do it, you should get the complete screen, which really should be blood tests and a rectal examination. But I always tell folks the blood test is a can't miss. It should be done annually. And it's got to be stopped at the right time, because we also don't want to be detecting cancers that are not going to impact your life. And the right time probably is somewhere around 70 or 75.
And yeah, can I jump in really quickly? Because I thought your JNCI article was great. A question that I have for you, because I actually do practice in the Cotton Belt. I'm in Charlotte, North Carolina, and I'm fortunate that I get to take care of a lot of men with prostate cancer and a lot of Black men with prostate cancer. And I will say that I've really had a bias toward beginning screening even as early as age 40. And just with the idea that maybe we don't do it every year, but it can at least get people on board. And I do think that early diagnosis of prostate cancer, particularly in young men, is where we're going to get the most bang for their buck. I can tell you anecdotally, the first person that I operated on for prostate cancer after my fellowship out in Seattle was a 49-year-old Black man. And that, really stuck with me. And so I was curious as to, was it that 45 just happened to hit the sweet spot? Is it that we're trying to avoid overdiagnosis, or we're trying to cut down on healthcare costs? What really drives 45 as opposed to 40 or 50 for that matter?
Yeah. So this is a kind of conversation that Jamie and I like to geek out about, because it's very quantitative and technical. But I'll summarize it as this: the gain, because remember, we're talking about a relative risk, so we're comparing it to no screening at all. The benefit gain from decreasing the age 5 years was absolutely minimal. And what that tells you is not that there's not a benefit to considering screening someone under the age of 40. It just tells you that not very many men at the age of 40 to 45, even among Black men, are being diagnosed with prostate cancer. So, I mean, for me, the 40 makes sense, right? If you're going to go in and get your colon cancer screen, maybe you just have your screening visit at age 40. I mean, there's got to be some things to think about from a practical standpoint. But that's how 45 sort of came to be the number in that study.
Jamie, if I can chime in for just a moment, I began my screening at age 40. And there was a history in my family. My dad had prostate cancer. So I began my screening at 40. And then eventually, I was diagnosed with prostate cancer at age 48. And so from 40 to, probably around 46 or so, my PSA was rising, and thank goodness and thank God for a wonderful primary care physician who I, had a relationship with almost 25 years. He started noticing an uptick in my PSA. And, so I was diagnosed at 40. And, if I didn't catch that early, and that's why I'm a big proponent of screening, and particularly if you have it in your family, I would say that 40-year-old mark is where you want to be starting. But yeah, so I think 40 is a great place to start, particularly with a family history. But here's the take on that. And a lot of, the stories I'm sharing are anecdotal, in that I had a friend a few weeks ago call me, and he and I are the same age. I'm 59 now. He was diagnosed with prostate cancer, and he said it ran in his family, but nobody wanted to have that conversation about cancer. And, so he was frustrated, and he said, Rob, he said, I wish I would have known this years ago, and maybe I could have changed my diet. You talk about environmental stress. I could have been yoga, all of these stress relieving things that could have, come together to at least kind of mitigate some of those things. And so, and I know we'll probably talk about this later, but, it gets back to that conversation about prostate cancer or cancer in general. I always hear people talk about, DNA and where they come from and what part of the globe they come from. But I think we also need to know what's in our family's health history, so that we can lead better lives, so we know what to eat, how to kind of stave off some of these things that are present in your family's bloodline.
I think that's an awesome point. And Robert, so how do you recommend that men go about initiating this conversation, both in their families, but then also how do we go about getting men to go see the doctor and get that PSA test, get that rectal exam, and really begin to engage with screening? Because I think that's such an important point.
Okay, so I'll start from this age now. I say the AARP crowd and folks of my age, because we've lived a pretty long life. You get to this stage of life and you're like, this is what life is about. I want to live longer. So guys like me, now we have that conversation about health. We want to be around to see our grandkids, and so the guys that I talk to in this age range, they pretty much get it now, because there's a reason why they want to live. I would say in terms of younger men, it gets back to kind of those social determinants. I think, because I was in the healthcare system for so many years, I was exposed to a doctor when I was younger. And so a doctor's visit wasn't something that was strange to me. And so therefore I didn't have any apprehension about going to the doctor, because it was just part of what we do. And I think, in certain communities, the doctor is the last place you want to go. And again, some of this gets back to Tuskegee and what people believe about health and who's really got their best interests at heart. So, I think when you are exposed to healthcare early, that helps you later on in life to kind of keep a check on what your life is going and where your life is going. And the other thing I would say, Jamie, again, it gets back to finding out your why. Why is life important to you? And once you find that out, then everything else seems to fall in play. Lao Tzu has this quote. It says, he who knows others is wise. He who knows himself is enlightened. See, people get to this age and they're enlightened. They love life. Okay, what do I need to do? Yeah, I'll get the test, and so I want more men to become enlightened about life and what it offers them. And see, when you do that, now your health is important. Now I want to be around and be vibrant for my wife and my kids. So again, it gets back to, I have to give somebody a reason why before I say, go get your PSA, get a DRE, get your prostate exam. If there's a why, you don't need much coaching to get them to the doctors.
Absolutely. I think that's great. And so once they get to the doctor, a couple of good questions are popping up in both the early questions we got and in the Q&A. So please keep asking these questions. We've talked about PSA, we've talked about rectal exam. What other tests do you think men should consider when trying to evaluate their prostate cancer risk? I mean, is there anything else that we should be doing? I know free PSA has been brought up. There's PHI, the Prostate Health Index. There's the 4K. There's Decipher. There's Polaris. There's prostate MRI. I'm just listing off a number of different tests, and I'm curious as to what your thoughts are on where those fit in. Have they been validated in Black men? Do they need to be validated in Black men? I mean, do we think that the biology has reason to be different? And also importantly, within that context, nothing is free, and these are expensive tests oftentimes that aren't covered by insurance. And so what do you both think about these adjunct beyond the PSA and the rectal exam and the family history when we're assessing men for risk, particularly Black men?
Yeah, I mean, I think this is an area where some conflation of biology and race has occurred, where patterns have been observed that might not be real. It's sort of like, we've had a lot of US presidents who've been left-handed allegedly. And so, but just because we've had that doesn't mean every left-handed person will be president, right? And I think we all understand that. So, tumor location and things of that nature, I find to not use that to drive my decision making around what happens in men. Because what I'm hearing is if someone's in that gray zone of maybe a positive test, should we be ordering more? And I will say this, in general, I'm a big believer of MRI because it improves biopsies. And I think we have a lot of data to suggest that. And so I would offer that to most men who are coming in with an elevated PSA, because I think I get them a better biopsy up front. And I think that would be true for Black men as well in my practice. But I certainly wouldn't make a blanket statement that needs to happen for all. People have looked at this. There have been some studies across the country looking at MRI in Black men. And I think what we found is that it helps detect significant cancers in the same way, and there aren't any location patterns that are unique. With regard to the adjunct tests, I have an even harder time in this space because I think that the added value of a lot of the tests is pretty incrementally small. Free PSA is super cheap. Most of you probably are getting it as part of your PSA anyways without even realizing it, and I think can be really helpful in making the decision. But to me, the more important thing is getting Black men to the doctor, in instances where they need to, advocating for the test, because men in this webinar probably are aware of this, but not every family care practitioner or primary care doc believes that the PSA test is necessary, and so you may have to speak up to get the test. I think that's more important, and getting it started at an early age than the other testing. I think you and your urologist can sort of sort out what you think will be good for you based off of what their preferences are and how you and that physician view the literature.
Robert, what are your thoughts on this?
Well, I think to me, it gets back to a level of trust with your doctor. I think, the more tests that are available, I think the better, because it gives you an option in terms of what you'd like to have used, if you will. But, I think it gets back to a relationship with your doctor, that if your doctor, knows your body, knows your history, he may say, well, look, here are a couple of tests. And let me tell you a little bit about each one of these. And the option is yours, but this is what I recommend. And you provide enough information, not that so much that it's overwhelming, but you allow the patient to have some ownership of their health outcomes. And I think that's the way to go, is to really, lean on your doctor for his or her expertise. And very quickly, one of the things that happens a lot, Jamie, is when men are newly diagnosed, they run to the internet, they find all of these different types of PSA tests and here and there and diets and all of this stuff. And they try to become the expert in this field. And, you find one positive article, Jamie, you go to another site and it contradicts what you just read, and it creates all of this smoke. And so I tell men, read about or get to know, what are some of the different procedures and the medicines that are available. So you have a general idea when your physician talks to you about these things that, okay, I don't know it all, but I'm familiar with it. And I think, you have to allow yourself to be a patient. Don't try to be the doctor and the patient. That's too confusing. Know enough about your own body, what's your outcomes, what do you want out of life? If the doctor says, hey, look, radical prostatectomy. Okay, can I have kids? And, so you have to take all of that into account before you make that kind of decision. And it really gets back to health, owning your health outcomes. And so, I wrap that up to say, the more products and services that are available, yes, that's great. But you really want to create that teamwork with your primary care physician to say, hey, look, doc, you know me, you know my body, you know my family, you know what I want out of life. Hey, what would you recommend? And again, if you have that trust level, I think that's how you eliminate some of the stress on your own body. And then, you're giving your physician, the power to help you out and navigate you through this experience.
Awesome. And like Yao said, we're both urologists. We both love to geek out on the data and these advanced tests and all of that. So I would ask you another question of what recommendation do you have to us as urologists and also to men watching who are patients who are then talking to urologists about how to really have these conversations so that way the patients or the men watching and joining the webinar tonight can get the most out of that conversation, recognizing that it is a limited time interaction and everyone wants to get the very most out of that interaction.
Sure. I would say first thing is, for one, knowing as the patient, know what your asks are. What are your questions when you go to see Jamie? He's got 15 minutes, to see you. What are some important questions that need to be answered? And don't, I think, just like we're calling each other on a first name basis, which is lovely. I'm not saying that's for everybody, but this is a journey. You're getting ready to go through this prostate cancer experience. You want a doctor who's there for you, and you want your doctor to understand your part of this as well. And that, Phil Shoka, a good friend of mine, he says, look, he's a prostate cancer survivor. He says, I can tell you what cancer, a doctor can tell you what prostate cancer is. I'm a survivor. I can tell you what prostate cancer is like. And so, the doctor also has to be willing to be vulnerable to hear more of these stories and what these men are feeling as they're going through this prostate cancer journey. So I think it's really a mutual journey that both the doctor and the patient have to take together, and be respectful of the time, but also, avail yourself to, that question that may come in the middle of the night and, text or email your doctor the next day. I think, sometimes we have to remove the barrier that I'm the patient, he's the doctor, and I really don't know anything. And so therefore, I want to ask this question about how's my sex life going to be after this prostate cancer journey? But, I'm too embarrassed. And maybe the doctor can initiate that conversation and relieve that stress that, he talked about just what I wanted to ask him. And so anecdotally, I've heard these stories where the doctors don't engage in that conversation about the sexual activity after prostate cancer. And so a lot of times they go to the doctor and they have a note card and they say, that's a little bit too much of a touchy subject, so I won't ask it. So maybe, I would say as a doctor is maybe you broach the subject first. Now you may get another half an hour of questions after that, but at least you relieve that stress, because for a lot of men, that's a big issue.
Absolutely. I think that's excellent advice. I appreciate hearing that. And just kind of to wrap up our discussion of diagnostics, there was a good question in the panel of, fluciclovine and PSMA scans have all been recently FDA approved in the diagnostic process of prostate cancer. And obviously prostate biopsies are no fun. They're uncomfortable. They're not without risk. Can men get away without having a prostate biopsy if we really want to get a diagnosis of prostate cancer? Yao, I want you to go on record and answer this question.
Putting me on the hot seat. No, I think there are very few cancers that we treat based off of an imaging study alone. Even here this is anecdotal experience with PET tracers like flucyclovine. We've had some, lesions that have been, quote, positive that after a surgical removal didn't really correspond with that clinically, meaning that it wasn't cancer. PSMA is going to be a game changer. I mean, I think we're, as a field, going to have to rethink what positive tests really mean and how we treat patients, because we're going to find a lot more cancers in different spots than we currently are. And I can't even pretend to have the answers as to what we're going to do with that information. But I think it's going to be really helpful for patients, and it's moving the field forward. I think if you told most urologists 20 years ago we'd have a tool this powerful for finding small amounts of cancer in the body, they wouldn't believe you, because we just didn't have that kind of technology at our fingertips.
But do you think, right now in 2021, if we want to diagnose a localized prostate cancer, so for the audience, a cancer that is confined to the prostate, not elsewhere in the body, and one that we generally consider to be curable, but that might need treatment, is the biopsy still necessary?
Yeah, absolutely. And there's a few reasons for that. It's one thing to know that the cancer is present. It's another to know how aggressive it is, how much there is. Now, we may get to a point where, the imaging modalities and technologies can give us that kind of information, but we're not there yet. And so biopsy is still going to be necessary, at least if you come see me.
No, me too. I just, for the record, I wanted to get that answer out of you, but I 100% agree with you, as somebody who does a lot of prostate biopsies. So for Robert, what resources are available to help men navigate through the system, as they're going from screening to diagnosis to treatment? There was actually a really great question that just came up in the chat is, why limit this to the physician office? Should we be doing wellness programs? Should we be going out into the community? What's out there for men?
Well, I'll say, of course, serving on the board of Zero, the End of Prostate Cancer, we have a program 0360, which is a service that is multi-layered, where we help newly diagnosed patients kind of navigate their way through this new journey. We can pair them up with a mentor who has gone through this experience. We also, it's really about wraparound services. We can help men get to appointments through, a service where we can get men or give them the allowance to get to an appointment and get back. And so we really try through 0360, we really try to take the burden off of the patient. You've got enough to worry about. We've got some services in the background that will help you navigate that. Everything through, your healthcare services, and how somebody can look through your healthcare package and say, okay, well, we can cover this. They don't cover this, and it really relieves the patients of a lot of anxiety. And then the other thing is really having the conversation with other men about some of their experiences. Having prostate cancer survivors share their story. There are a lot of men that choose not to share their story because of some of the side effects of their prostate cancer journey, and so they're reticent to share those experiences. And hey, look, Jamie, I'll tell you, I had no thought whatsoever about sharing my story about prostate cancer. I was going to be probably one of the army of other men. I call it the reluctant brotherhood. Hey, I didn't ask to be in this club. I'm in it, but I'm keeping my mouth shut. I'm not telling anybody I had this. And, what helped me come through that is sharing my story with others. So I think survivors really can help other men by sharing their stories, in terms of letting them know what's upcoming, how to handle that. And, I think that's one of the best ways we can do that.
Awesome. And, I think I do want to put in a plug for the S2 support groups as well. I think that is an example of a place where people can go. And I know many of the men in our audience probably participate. Yeah, similar question for you. Oh, sorry, Robert. It looks like
I'll share this with you. One of the first calls that I made when I was newly diagnosed, I reached out to Terry Lakowski at Us2. And so the support group network is awesome. And again, she picked up the phone, a welcoming voice, and I got tied into a network of other survivors. So it's really important. So I'm glad you brought that up as well.
Awesome. And yeah, a similar question for you, but from somebody who works in in a big hospital system and in a cancer center, what resources are available kind of from the medical side that could potentially help men navigate through the system?
Yeah, great question. I mean, a few things that I wanted to touch on real quick. I was, this is an aside, but I was looking for an accountant, and I was talking to my buddy, and I was like, what do I need in a good accountant? Do they need a official title? Should I be looking at where they trained and, how big their firm is? And he said to me, you want to pick your accountant like you do your doctor. You gotta trust him. You gotta have it. You feel comfortable talking to him. And I sort of had this moment where I realized that, as much as the degrees and where people trained and all where they're at matter, may matter. The truth of the fact is that interpersonal relationship, that trust that you build, that ability to be comfortable and having conversations is paramount to getting good quality care. And I think people should really learn to ask for that, because I'll tell you, some of my patients demand that. They're not afraid to ask of that from us, and others are sort of more reactionary in how they receive information and interact. From a cancer, standpoint, resources, the first thing I do is I send patients to the patient guides, whether it be a Prostate Cancer Foundation. I let them know about support services like the groups in us too, because I do think that when you get that phone call from me of, hey, you have cancer, the first thing that you are looking for is information. And that is the worst time, from my perspective, to start talking about options, especially for prostate cancer, where we have a lot of time to figure out what's the best fit for you. Once we get that baseline package of reliable information to you, then I think, when you come to the office, it's about understanding. For us, it's a team approach. I will gladly recommend you to other urologists. I'll gladly recommend you to radiation specialists, and I'll gladly give you all the resources that you need in your clinic visit. For at-risk populations, I use that in quotations, but just for higher risk populations, for us, we have indigenous populations that don't have are not as well resourced as our Amazon, employees, our African American and Black populations. We have a really robust patient navigation system. A patient navigator is really an incredible resource, right? That's someone that can come in and just help you understand where you need to be, what things that you should be asking for, what boxes need to be checked. And in the process, they can do a financial assessment and tie folks to resources that, remember, healthcare institutions are nonprofit. So if we're sitting on profits, then they have to be used for the mission of the institution, which is delivering care. So there's a lot of things that exist within the milieu of a cancer center that a navigation system can really help. The patient navigator was popularized in New York and really showed tremendous decreases in cancer-related disparities, and that's been demonstrated not just at its original site but other institutions. So those are, I think, a few things that are sort of important to keep in mind and just know that are available at our centers.
And I would like to echo that concept of patient navigators. I'm fortunate to work with an excellent team of nurse navigators where I work, and they just do an amazing job with coordinating with my patients, making sure that they know how to get to their appointments, what appointments they need, and coordinate between teams. Because I know that a lot of us, it's not just urology. Patients, it's a multidisciplinary team that we have medical oncologists, we have radiation oncologists, but there's also social workers and financial counselors. And they're just absolutely amazing, because I know as a physician, there's only so much I can do. And so I think recognizing that is really important, and the teamwork that goes with that. So I think that's an awesome point to bring up. a question I wanted to throw out to both of you on the panel that I think goes along with this, but this was a question we got through the chat, was from Brian Jarvis. He's a 65-year-old Black man who says he's had all of the advantages of insurance and doctors and great jobs and good environments and access to food, advanced degrees. And I wanted to get your thoughts on navigating the system as a Black man, even with all of the advantages, all the social determinant advantages, and how that might be different, or what is unique, and what our viewers might find interesting about that.
Well, I would, with all of the, because it seems like all of his boxes are checked, and a lot of times, I know it happened to me that when I was first diagnosed, I'm like, look, I had the good job and nice neighborhood and good educational background and everything, and so it was, why me? And so I think that in and of itself, and to my point, then it became a question of my faith, because I'm like, I've got all the boxes checked, good family and everything. Why is this happening to me? And so I know psychologically, some folks and some guys that I've talked to, they're like, I thought I did everything right. And here it is, I've got prostate cancer. And so that does a number on people, because you hey, you go to church every week, you pay your bills on time, you love your kids, hug your wife and all of this stuff. And then it's kind of a why me? And so I found that to be prevalent with some guys that, they feel like it's unjust to them. I've done everything right. And now sometimes it leads into a faith issue. Like, all right, what did I do wrong? And so some of these guys say, I can't win for losing. I've done all the right things, but then this happens to me. And so that's what I found, and particularly in the case that you just mentioned, where, great healthcare access, all of this stuff, and then this happens to me. Now, interestingly enough, that, some of these same men that I've talked to after they've been treated and they've gone about their lives and successful surgical outcomes, what I did notice with them, Jamie, is they had a new outlook on life, and everything that they thought they had prior to prostate cancer, afterwards, it was like, man, that really wasn't all that life was about, and so there's this shift in their belief, and like they get this, again, maybe this phase of enlightenment where, wow, I've been chasing all of this all my life, the good schools, the education and family and, all of this. And then post-cancer, they say, while they didn't want prostate cancer, as a result of that, they say, what, I did learn something through that process. So it's an interesting dynamic that goes on in terms of, having all the right boxes checked pre-cancer, and then afterwards, it's a totally different outcome.
Yeah, a couple of comments. I mean, the first thing is prostate cancer is extremely common, right? 1 in 9 men in their lifetime, if we take everybody. And so sometimes the advantages of those social determinants are not going to be in taking away your lifetime risk or getting the disease. It's going to be at what stage and what options and capability are you going to have to do something about it that can, positively impact your life or extend your life. And so I think about that framework a lot, because, in one realm, I can say, well, your social status might lead you to get cancer, which may be true, right? Pollution, et cetera, things we've talked about, stress. On the other hand, I could also say, well, even if you don't have those negative social parameters, you could still get the disease. So then how does the social factors impact what happens after you're diagnosed? And so I try to separate those oftentimes in the research that I do. The other thing that I will mention is the concept of John Henryism, and John Henry. The story of John Henry is of a Black man working so hard to meet the high bar of having the nice car, the nice home, that social status, and in doing so, working himself into illness. And so, I think we can't discredit, what it takes oftentimes to reach those milestones for people of disadvantaged backgrounds who may be starting not on the same level playing field. And for me, I think about it. I mean, my father's a biochemist, all right? So I'm not an example of this, but I remember calling my dad at med school in Chicago and saying, like, none of my classmates are like the son of a janitor, or the son of true blue collar working person. For the most part, like, everyone I talk to has a parent who's a physician or a lawyer or a business person, it seems like, right? And so for that one or two classmates of mine who might have come from truly, a more disadvantaged background, you have to wonder what their physical, emotional stress has been to get through that kind of a system. Because it is, as you may know, when you check a lot of those boxes, there's a capital investment you make to get there. So it's a great question.
So kind of moving on so for men who are diagnosed with prostate cancer, about 50-ish% of newly diagnosed prostate cancers fall into a low risk or very low risk category that may benefit from watching with active surveillance, or really keeping a close eye on it, versus jumping straight to something more aggressive like radiation or surgery. Question for both of you is twofold. One is that safe for Black men? And two, if it is, how do we have that conversation, recognizing all of the history of the medical system and the distrust and the mistreatment and undertreatment of Black men for the last several hundred years, and unpackaging all of that together?
Yeah. So I'll start, and I'd love to hear Robert's take on this as a patient and survivor. The answer for me is yes, it's safe. It's safe for a lot of reasons. And so when we talk about disparities or inequities, we have the potential to overtreat, right? I talked about examples of people getting procedures that didn't need. To me, a low-risk cancer is a low-risk cancer. When we talk about aggressiveness of disease among Black men, one of the hallmarks of that tends to be advanced disease at diagnosis. And we say, well, maybe the progression from a cancer that is localized and curable to non-curable is shorter in Black men. So that, the disease is more aggressive. But the truth of the matter is that probably just reflects lack of screening, and so you're more likely to have missed that window over probably the course of years to decades, where your cancer could have been detected and potentially treated early. Several studies have been done. We've done it here at PASS that show a variety of different outcomes, but the main takeaway from all of them is that active surveillance as a strategy doesn't increase.
And really quickly, what is PASS?
So PASS is the Canary Pass trial is an active surveillance study here, led out of University of Washington, Fred Hutch, that has multiple sites across the country, and it's a study that has a standardized protocol for how active surveillance is done, and it's the largest prospective, meaning we're collecting ahead of time and following people in real time, surveillance trial in the world currently. And so the study that was done from that past, looking at Black men versus white men, essentially showed no difference in any of the outcomes that were measured, whether you progressed to treatment or had metastatic disease, which we use as a proxy for for having lethal prostate cancer. Even in the studies that have shown that Black men might be more likely to progress to treatment, that progression didn't lead to any adverse outcomes in those studies. So for me, it's simple. Put them on active surveillance, follow the protocol very, very tightly. I spent a lot of time trying to build trust around the safety of it. And I barter, if I typically do my surveillance biopsy at a year. If I see someone is apprehensive, I know I can move that up to 6 months and do that safely. And sometimes that's what it takes for confidence. And when I say barter, maybe that's not the right term, but really it's a negotiation for me. And it's about doing what a man's comfortable with that surveillance strategy. And sometimes, and I give people the option for treatment. And so I don't presume to know what's best for any individual patient, but I put it on the table, and I think it absolutely has to be on the table.
Sure. Well,
Robert, I'd love to hear your thoughts.
Sure. In my case, again, because I had a relationship with my doctor over several years, he was able to keep track of my PSA and how it was tracked and rising over the years. And so, therefore, it took away the surprise of saying, you've got prostate cancer. And again, that's why it's so important to be in that pipeline, to have a relationship with a physician, because your doctor knows you. You're in the system. I think what's overwhelming for a lot of men who don't have a history visiting the doctor, that when you finally go, now you've gone from, and this gets to what y'all were saying about the different levels of the cancer. Now, because you've missed so many appointments over the years, now you're at a stage where it is no really monitoring and keeping a check on this. For some men, you're right there. You need to get treated. You have to begin treatments. And so therefore, that's trauma in and of itself, because now you're thrust in to a situation where you really don't have a lot of options. You need to get treated, but now you're forced into this, okay, I've got to do something. So now your mind is clouded with all of this stuff that has to go on, where I think that a longer relationship with a doctor who knows your family history, knows your body, knows your history, you never want to go down that path. But at least if you do get that diagnosis, it's like, okay, all right, doc, what do I do next? And now you've got that coach, that guide to get you through the next piece. I'll just share this. In my case, I was diagnosed at 48. My cancer wasn't as aggressive, so I caught it early. But the thing, I had my daughters already. I'm already married. And I remember telling my doctor, look, I just want it out. You hear cancer, no active surveillance for me. My dad died from prostate cancer. This is what I want. And again, it gets back to knowing your situation and knowing what you want and taking ownership of your body and having that conversation and be upfront and honest and say, hey, look, these are my concerns. This is what I'm feeling. This is what my wife is feeling. We collectively talked about this, and this is the route that we want to go. And so, like, in the case of y'all seems to, hey, look, here's the plate here. We can do this, we can do this, and this. Hey, look, I'll coach you through this, but ultimately, y'all wants them to take some ownership of that health outcome as well. So in my case, once I found out that I had it, it was radical prostatectomy for me. And in terms of family and all, I checked those boxes, so I was okay with my decision. And the other thing is again, a successful outcome, and post cancer, it wasn't a lot of, oh, I should have done this treatment or that, so that helped me out, having a really good team to say, okay, look, these are the next steps. This is what I think would work best for you. So that's really important.
And Robert, something you said there just really struck me. You said your dad died from prostate cancer, and that really colored your personal journey and understanding. Could you share a little more about that and what men should think about?
Correct the record. And my dad had a bout of prostate cancer. He eventually died from lung cancer. But here's what's interesting about that, Jamie, is that initially he didn't want the family to know. I've got two other brothers, and he didn't want us to know because, you know, typically in most communities, cancer is a bad word, but in the African American community, cancer, it's a death sentence right off the bat. You know, for most people, they're like, cancer is going to take you out. And so, you know, we know when you bring up the word cancer, all kinds of things will well up. And my dad didn't want us worrying. And I thought I was alone in that. And a lot of prostate cancer patients that I talked to and survivors, you know, they said the same thing, that their dads didn't want the family worrying about their cancer. And so therefore, a lot of times they didn't know that the dad was even treated for prostate cancer.
This brings up a point that I'm really passionate about, because in the last few years, we've had studies, and I'm contributing to this, so I'm not knocking the studies, but we've had them show that if you take a Black man and a white man with the same grade and the same stage of disease, and you give them the same high quality treatment, that the outcomes are the same, right? And the first problem with that is that Black men don't present with the same grade and stage of disease. So, you know, that might be true, but that's not reality of how the disease is. But I think that also the access to high quality care and just care in general can vary a great deal based off of where you live and, you know, your means. And so when we talk about what is the right treatment for me based off of, you know, my race, ethnicity, and should I get, you know, standard of care or not, I feel like the starting place is always standard of care, which for low risk cancer is active surveillance and brachytherapy and external beam and surgery. Now, I think a lot of us would prefer active surveillance first because we know we can do it safely. But 50% of men are going to get treated on active surveillance, and that's been proven in a bunch of different series. So it's somewhat a delay of care. But it's important to me that if we're starting on that mantra that outcomes can be similar by presenting the same quality care, then why would I change my routine because you came to the door with a different skin color? For me, it's important that I give you that same product that everybody else gets. Now, what we decide to do together, you know, if Robert was my patient and he said surgery, I wouldn't spend half an hour talking him out of it. That's not meeting him where he's at. And so those are two very different questions.
And I think that segues into a really good set of questions we got both in the Q&A and the pre-questions of radiation versus surgery. And one question asked whether radiation is more effective in Black men than in white men, but other questions and I think data have suggested that Black men are disproportionately more likely to elect radiation as opposed to surgery for their initial treatment of localized cancer. And I was curious as to both of your thoughts on that phenomenon and what's driving that.
I'll start with I opted for surgery, but a majority of the men that I talk to, Jamie, they're like, you're not cutting me open. I'll go with the radiation. It's just something about surgery, you know, where it conjures up this feeling of something could go wrong when my body is open. And so most of the men that I've talked to, a lot of them have elected radiation because they didn't want anything invasive. Now, again, here it is, you know, and I'm talking to most of the men that I've been having conversations with range from about 45 to about 65. So, you know, they're in an age range where like, you know, I'm not comfortable with surgery, so I'll do radiation. So it gets to that point where, you know, at this age, I'm like, oh, no surgery for me. So they look for other options that are less invasive in most cases.
Yeah, a couple of reasons. First of all, Black men are more likely to not get any treatment, so that is a problem that needs to be addressed in general. And I think we have research that we want to do in this space and are going to do to address that. radiation treatment, listen, some men can get that on their lunch break or, short treatment during the week. We take for granted, oh, you're going to be out a week or 4 weeks. Not every man has that flexibility in their jobs and their career. We talked about medical mistrust. It's not only just about the fear of not waking up, but it's also the stories that live in people's families and are real, of going to, the big cancer center in town and being part of an experiment, so to speak. So I think that there's a lot of reasons why surgery is not a preferred modality, but rather than you, me, and Robert talking about this, what the real answer needs to be questioning men directly and sort of understanding what the real drivers are. And if it's something that really is a preference, and great, but if it is out of misconceptions, then maybe there's an opportunity where we can better educate and inform and provide resources to get men the care that they desire and seek.
Jamie, can I quickly add that when we talked about trials earlier, y'all mentioned it a little bit in his presentation. One of the things that I found disturbing is that when my doctor was laying out different options, when I asked him for data about how radiation and hormone therapy, what was the outcomes for Black men? And he didn't really have any data to show me a huge volume of Black men that participated in the study. And so, that slanted my decision in another direction. But, that's the other thing is particularly for Black men, we also had to leave some type of medical footprint behind for the next generation so that they can make informed decisions based on treatments that were given to Black men. So they know, there's data to support whether or not they want to take a particular type of treatment. And so that was a little disappointing because the numbers weren't there to help me make a decision as to how that treatment would affect me as a Black man.
And Robert, I think that's an awesome point. I know we're getting toward the end of our allotted time, but this is such an important concept to bring up. And so how do we get more Black men to engage in trials so we can so people like Yao and I can talk to our Black patients and say, yes, we have data that says this is how you are going to do, or how we think, or how men like you do when we do treatment X, Y, or Z?
Well, I think what Black men need to see is more people that look like them and that are involved in the process of the clinical trials, some of the development of them, and have a sense that I know you've got my back. You understand my family history. You understand what it is, quite frankly, to be an African American. And so seeing more people involved in the development of these trials, I think is what's going to win folks over. But also, there's also some education that goes along with that to say, okay, how is this data going to be used? Who will benefit? People love to leave a legacy, but you got to give them a reason why to leave one. And so the more you can tell them about this trial, who it will help, how it will help, who are the investigators, what will happen with this data once you get it. Those are the things that we have to answer before you really get buy-in to say, okay, is this some kind of clandestine effort to take my cells and give them to somebody else, or how will it be used? So I think seeing more people that look like the population that you're targeting is essential to get them to participate in the trials.
Yeah, I mean, I alluded to this in my talk, but we're doing a study here in Seattle, and the first thing I did was get community partners to help. What we're doing making sense, right? And in the process, we're learning things that would have been mistakes that we would have made in how we engage with the community. I mean, the majority of these trials that we talk about are happening at centers that don't provide care to predominant, underrepresented minority and Black populations. So I think we have to be creative at the clinical trial, cooperative level, which is happening. But until we make the conversation and the efforts about Black men. And by that, I mean center it around them, make them active, not only participants as study subjects, but participants in the trial design and the collection of data, intentionally reporting outcomes. I can't tell you how many times I've heard patients say, yeah, I participated in a trial, I have no idea what happened to it. Having a community readout, I've learned this from my partners. Well, tell us what you found. That's an important way to build trust. There are a lot of strategies that exist, but it starts with being intentional and centering Black men at the conversation.
Awesome. Well, we have 2 minutes left. This has been absolutely awesome. I'd love to get any final thoughts from both of you that you may have for closing up this discussion tonight.
For me, it's simple. I think Robert said it earlier. When the C word comes into the minds of Black men, I think there is a sense of hopelessness based off the statistics, right? I started off by saying Black men are twice as likely to die from prostate cancer. I think that fear, even of a diagnosis, that can be paralyzing in this disease process, that we know early detection can be curative and really extend life. So I just hope that we can find ways to continue having these conversations, and we can find ways to extend our reach when we have these conversations to younger populations where the benefit can be even greater. And I'm really thankful to us too for creating this space for Robert and myself to speak today. This is a really special moment for us as a community and for me personally.
Jamie, I would echo what y'all said in terms of, for one, thanking us too for, allowing us to come together and talk about this issue. I think many more conversations need to be had about generally what do you want out of life, and depending on what you want will really determine what your health outcome is going to be and how you treat health. And I think if you measure your health as a source of your wealth, you will make sure that you stay healthy, and Lord willing, you'll be wealthy. So I think that's the way to look at it, is that you've got to be healthy to create a good life for yourself and your family and friends, and participate in life and give it its all. So if you can identify your why and what your reason is, then your health will be your top priority.
Well, Jan, Robert, thank you so much. This was really an amazing conversation. I appreciate both of you taking the time tonight to speak together and to our audience tonight. I also do want to say thank you to our sponsors, the Pfizer Foundation, AstraZeneca, Janssen, Astellas, and the state of Illinois. And I'd like to invite the audience to our upcoming events. We have Zero, the End of Prostate Cancer's inaugural Racial Disparities in Prostate Cancer Symposium. That's going to be Thursday, June 24th, from 10 a.m. to 2 p.m. Eastern Time. And we also have some upcoming webinars. We have Imaging in Prostate Cancer on June 24th with Dr. Lawrence Klotz and Dr. Brian Helfand. And then on Thursday, July 29th, we have Genetics and Genomics with Dr. Heather H. Cheng and Dr. Brittany Sismaniak. So again, thank you everyone for attending tonight. We look forward to seeing you in the future.